Venkat is a dear friend. Again, I must thank Neeraj Jain and Ankur Mukreja for introducing Venkat to me. I didn't know him until last month when I got in touch. G Venkateswaran or Venkat is a management graduate with nearly 25 years of work in corporate health as well as public health sectors. Areas of expertise include strategic planning, technical and thought leadership, policy advocacy, stakeholder engagement, partnership development, strategic program design and deployment for greater impact and scale up. He's been with SPARC, Seattle-based NGO that works across multiple continents, Africa, South America, India, Asia. For over 3 years, he is currently the lead for strategy and business development for India and the South Asia region. He has worked at PATH and worked with the WHO to develop Southeast Asia regional roadmap for diagnostic preparedness, integrated laboratory networking, and genomic surveillance. Venkat has also steered his own startup in the social sector for advisory services specializing in corporate communications and public relations. Warm welcome, Venkat. We're really excited to hear about you on lessons from the Living Labs initiative. Warm welcome.
Thank you.
Please.
Thank you. Thanks. Okay, so before I start my presentation, I just wanted to know how many of us, so I understand that we are people of Indian nationality and Australian nationality. Any other nationality in the room other than these two? Great. So I'll give you a cricket analogy. The way I'm going to kind of set up my presentation is into three parts. First part is going to the power play, which is going to set the foundation. Then we're going to have the consolidation phase, the middle overs, and in the last, we'll have a slog over. So the engagement, I mean, it will be a two-way engagement in the power play and in the slog over. So I expect a lot of discussions happening. It won't be a one-way presentation except the consolidation phase. Okay, so let's start with my question. I'm not going to start with Living Labs straight away. So let's start talking about the first thing. How many of us have ketchup, tomato ketchup? I just want to raise your hands. You had ketchup, right? What is the color of your ketchup? Red. Universally red. That's what we know about, right? Great. How many of us know this company? Great. What do they make? Ketchup, right. So in 2000, Heinz, the company that manufactures ketchup, and they have a huge market share in US and Canada. North America, almost 72 to 75% market is owned by them. So they decided to do something new. They decided to add an unexpected twist to their ketchup to attract children. What do you think they did? Wild guess. What do you think they did?
Added comic characters.
Added comic characters. Great point. Anything else?
They made it green.
They made it green. Okay.
Sweet.
Sweet. Okay. Increase the sweetness. Great. Any other thoughts?
Added the squeezy bottle.
Added the squeezy bottle. Great. One more I'll take. Well, I mean, you were pretty close to it. So they launched a product called Easy Squeeze. It was a colored ketchup. They launched it in 3 colors: teal, green, and purple. What could have gone wrong? It was taken off the shelf in 6 years. I mean, I'll try to connect why I'm setting the power play. This is the power play happening to the consolidation phase. What went wrong? What went wrong was they could no longer call it a tomato ketchup. Tomato ketchup is red in color. So one, that happened. Secondly, children started disliking it because once they mixed up the colors, it turned dark brown. People started saying it's gooey in color. Parents didn't like it because once the color changed from red to another, they realized, okay, artificial agents are being added. What about our children's health? And most cases, parents will not give their children what they don't eat themselves. So they were taken off shelf. So, big question. What went wrong? Where did Heinz go wrong?
They asked the wrong questions for innovation.
Great. They asked the wrong questions. Any other thoughts?
It was tomato ketchup.
It was supposed to be originally tomato ketchup. Yeah, they tried to bring it. They would try to make it other than red. Great. Okay. Because I say it's a slog over, so it's a power play. I'm not going to take a lot of time. The first 10 overs. Okay, so this is what we call as the design reality gap. The design reality gap is basically when the designers, Heinz company, design something without understanding the reality on ground. And most of the time, or many of the times, when we do innovations, when we invent things, when we bring in new technology, and when I mean technology, I don't just mean digital technology, I just mean technology, anything that's being brought in. We've seen that people bring in experts, we go in as experts, we go as if we know the design without matching with the reality. And there are often times when we fail. And there is where the living lab comes. Okay, before I get into living labs, how many of us have heard of living labs? Just by a raise of hand. Great. So our Australian friends have heard of living labs. Great. So let me talk to you a bit about what living labs is. So I'll just give you a history. I mean, the first time when somebody even talked of living laboratory was in 1749. It was done by Thomas Knight. But when he talked of, he was an alchemist. When he talked of living laboratory, he basically talked of the human body. That was the general context, that human body is a living laboratory. A lot of things are happening, a lot of interfaces are happening and all. But then over a period of time, it has been developed. I mean, like early 1990s, I mean, it was developed in MIT by William Mitchell. I mean, very popular with the entire idea of how the living labs got conceptualized, how it got into a space and all. And then it has got expanded and diversified in the 2000s. What I'm trying to tell you is there's a journey that living labs have taken place. And living labs primarily, I don't want to get into a specific definition of it. One, it is an open ecosystem which allows people to co-create. It allows people to explore new ideas. It allows people to test and evaluate what they're doing in real world environment. It's not somewhere done in a laboratory. It is called a living lab because it is done, taken into the community, with the community, implemented, and solutions are evolved. And the best part is it's an iterative process. It's not that you implement it once, if it fails, it ends. You learn, you go back to the cycle again. So that's how the living labs work. There are basically 6 characteristics that we define in path, and I believe even globally, which one can say, okay, if you have these 6 characteristics, you are operating in a living lab. First, it has to be operating in a real life context. Doing something in the laboratory or let's say in a closed room with 4 or 5 people is not what living lab is. Living lab takes the problems from the community, in the community, and it takes the solutions from the community, implements it in the community, sees actions taking place in the community. It has to be happening in a real life context. It focuses on user needs. The user context is extremely important in a living lab. Not something that we have theorized, that we've seen outside or drawn from books, but it goes into the community, understands what their needs are, how do they behave, what are their challenges, and then addresses them. It has a very active user involvement. And this is one piece that Living Labs focuses on. Co-creation, as I said, co-create, find co-solutions. It's not just with the users. It works across multiple, and I'll give you examples to demonstrate how Living Labs work across multiple stakeholders. And as I said, it's iterative. For path, I mean, what we have done is we have taken the living labs approach and we've adopted it into what can be done for health solutions. So what we have done, I mean, we adopted living labs way back in 2019. We call it the living paths living labs initiative, and we've applied it across multiple continents. I think almost 72 different projects where we involved the living labs initiative and all. The primary idea was for us to partner with the end users to co-create solutions, to accelerate health innovations, health technologies which can be of benefit to the people. So our context was health, co-create solutions with the communities and the end users, accelerate solutions is what we were looking at. And what I'm sharing is this is the way we see living labs work, the process, the 4-step approach or the 4D approach that we call it. It is, I mean, there's no defined way how living labs work. I mean, there are different ways people have said living lab work. This is what Path sees. We call it 4Ds. The first thing that we call is discover. This is where we work with the community to understand the context, what their needs are. Sorry if I'm too close to the mic. What their needs are, and once that's done, again we work with the community to analyze what are we learning, how are we defining the problem, what is the exact root causes of the problem with the community, what is it that we can bring in from the community as far as the insights are concerned. And now when I say community, please don't just look at the end user. We, for example, if I give an example of, let's say, us using Living Lab, and there will be certain case studies that we'll try to demonstrate with. So if, let's say, in case of India context, if I look at community, again, I'll take example of what Sujit was talking about, let's say malnutrition. We would have done our interventions, or we have done our interventions with, let's say, women and men in villages, if it's a rural focused nutrition intervention, with the health workers, with their supervisors. We would have had those conversations with district officials, health and WCD officials sitting together. We would have also had conversations with state level officials, brought everything together, because the knowledge permeates across the system, and then develop solutions with the community. That's what we do in terms of defining. When we say dream, this is where we look at ideas, preferably ideas drawn from the end beneficiaries and end users, and then we look at designing it. Designing is again done with the community to look at what is the impact. But this is not a linear process. As I say, it's an iterative process. So we do go back and see how things are happening. And in case we feel that the solutions are not happening to the level that we were intending it to, the process begins again. So it goes on till we find jointly with the community a solution that is acceptable, scalable at the community level. This is just to cite how living labs work in our ecosystem. I'm going to take examples from both Africa and India, what we did. So if I take example of, and this is an example of, let's say, a place where we worked with the nurses in Africa. This is Kenya, where we worked with nurses. Primarily, we understood that there were a certain level of demotivation that health workers were having related to the immunization services that they were providing. And we try to understand what is the problem, how do we define the problem, and realize one of the major challenges, they're not able to follow up with people who are defaulting on the immunization. They would come for the first dose, second dose, miss out the subsequent doses and all. They will not complete the immunization cycle and all. So that is what was becoming a problem for them, to getting them demotivated to follow up more, and because they were losing those people. Other thing that we realize is WhatsApp is a very common mode of communication among them, and something that can be deployed on a WhatsApp is something that they would take forward. And they were also willing, they were part of this entire conversation when we were also co-solutioning with them. And what we did is we developed a solution which was a technological solution, I would say, which can enable messages coming on their WhatsApp about the follow-up updates. Who do they need to follow up by when, for what particular dose of immunization and all. And over a period of time, we saw the immunization uptake go up in that community. And now this is getting more and more integrated through their Ministry of Health in Kenya. So that's one example of how we worked across multiple stakeholders in terms of, discovering, defining, dreaming, and then deploying solutions. I want to come to a few examples, and I want to now do a case study with you guys. So the way we'll do is I'll share a couple of case studies. I'll share the challenge. And I want you to tell me, how do you think Path went about doing it, what we did. So this is an example from India. So the problem case that we identified was, we have a troika of frontline health workers we are aware of, right? Ashas, Anganwadis, and ANMs. Now, they were facing a particular challenge. I mean, we're all aware of the nutrition programs that are running, the Anemia Mukt Bharat that is running. They are giving, let's say, a lot of supplementary nutrition and IFA supplementation and all to the community. Those are being given. But some of the points that came out during our discussions with them, and this is specifically in two states, UP and Bihar, where we did this exercise, is that they were facing challenge in tracking whether the IFA tablets were really being consumed, and to what level was the consumption taking place, to what level the adherence was happening. So this was a challenge that they presented. It's not that there were other challenges as well, but we don't want to dive into it, because this was a particular challenge that we really picked up, that they have IFA tablets, they're giving it to the pregnant women and children, they're giving it to the mothers after birth as well, but they are not able to effectively track how many are consuming, what are the consumption challenges and all. What do you think we would have done? What was the exercise that we undertook? What was the solution that might have come out using living labs? Any ideas? Yeah.
sir, you are basically talking about the monitoring, what the tablet is provided for the women, and they are consuming that thing or not. So yes, there is a one or two thing that if the anybody who is taking that type of tablet, there is some composition is involved in the blood system, and based on blood, if we have some sensing and we have some marker which they can detect. So based on blood report, you can say like that, yes, these women are taking or not.
So remember, like we are talking about the frontline workers, Asha, Anganwadi, ANMs. They usually would not have access to biomarkers to track. I mean, like so the people who are experiencing problem are the frontline workers. They wanted a solution. So how would you go about? How do you, not you? How do you think we would have gone about doing it? That's a good idea. I mean, biomarkers are being used, but I think the at the frontline level.
Because this is a very easy. I think in each and every or maybe 2 or 3 month gap, women are going to test for the blood test for the different types of markers or even parameters for the healthy child. If we add that marker as well, so we have the idea that okay, everything is going on, or what is the consumer. If we talk about the consumption, so we can take even concentration test as well. So both have
Good
that.
thoughts.
Yeah.
I'll add what we did.
Yeah.
We actually used two different kind of exercises. Sorry, Anita. Yeah.
Ask for the color of the stool.
Ask for the color of the stool. That's one way to kind of look at it. True. Any other thoughts that we can look at? So I'll just share what we did. We had a series of, let's say, discussions with, I won't just say frontline workers, the 3 frontline workers independently, people in the community, also with the gatekeepers in the community, with others, with, let's say, the CDPOs and the Anganwadi setup as well as with the health setup. We had those conversations, and as part we did 2 exercises, what we call as divergent exercises, which is basically to find out what exactly is the problem and where solution. And for solutioning, we did a lot of what we say is I'm not put it over here, the convergent exercises. Now, once we did that, we realized that there are 2 solutions that Anganwadi workers, Ashas, ANM themselves, and the immediate supervisors can implement. One was to look at encouraging community level leaders to come and advocate for or support in terms of this entire IFA tablet consumption by different community groups. When I say community groups, these are population groups: pregnant women, lactating women, adolescent girls, all those scale. They said that's one thing that they would want. Not many of the community leaders were so vocal about it. The second thing that they said is they would be looking at recognizing women who were completing the course. I mean, these were things which are very simple for them to implement, which they need a little bit of support. As I said, low cost, frugal interventions that they agreed to do. And I'm not saying that has been a success yet, because this is something that's happened in 2004. We're still tracking how those are making changes in the terms of greater adherence to it. So that's one. I'll take you to the next one. Sorry.
Can I make a suggestion?
Sure.
Please, Rolu.
Please.
There could be several answers to the question which you are pressing right now.
Right.
Now, one of the similar issue was the TV program.
Mm-hmm.
We were very keen that the people who are taking tuberculosis medicines must take it. More than the anemia and tuberculosis.
Yeah.
What they did was they started a dots.
Dots, exactly.
And so you can do the same thing in anemia also. That you make sure that the women who are there, they will come and collect the.
But what I
Yeah.
want to add is that
Yeah.
we are sitting here, how many of us have taken IFA tablet of the government? Right? Please raise your hand. How many of us have taken IFA tablet?
Yeah. No, I agree. Many may not have taken. Many might have even gone to a government health setup for services. Very true.
So when I took it, for example, I am a pitta person.
Uh,
I catch acidity very easily. If I take it, we are burning in the abdomen.
So most women don't accept it.
So I understand that there those some of the problems. The problem that also, let's say, the health workers face is, let's say if IFA tablets are given, for them to know why someone has discontinued, they need to know that someone has discontinued. That's the first step, right? if they don't know someone is discontinued, that makes it difficult for them even to kind of engage, counsel, and see what is the solution to be provided. So the problem, one of the problems that they highlighted was it's become difficult for them to track everyone who's discontinuing it or everyone who's continuing it. So there were other solutions that they were looking at. And when we were trying to help them with the solution, work with them, I won't say help them, work with them with the solutions was something that can be implemented at their level, something that need not be taken to 3 levels up and then brought down into the system. So yes, you're very right. Not everyone goes into the health system to take services. There are challenges, but I think their problem was we want to find out who is discontinuing for us to then follow up and all.
I just want to add one more.
Yeah.
We were seeing the presentation of Dr. Sujit showing the data.
Yeah.
The data itself accepts that compliance is only 35%.
Right.
As of now.
True.
That too is not a continuous basis because of the very many complications happening with the sort of use.
Right.
So that itself is a concern.
True. I take that, yeah.
So I wanted to ask you a question that you said you had discussions with all the things. So one discussion with the group of patients who've been administered the IFP tablets you have to take. If you even had a sample from them and you could have easily asked or come to the root cause of the problem, why or why not will you take this tablet or will you not take this tablet, what happens, and that point I find is missing.
So we did that. So I'll tell you what, I mean, this is a very small piece of the exercise that we took. I mean, the report is almost, let's say, an 80-page report, which has got several supply side, demand side challenges identified and solutions. It's not like a one problem, one solution that we did. So you're right. We did talk to the community, beneficiaries and all.
But again, you have put this to one size fits all. You've given one tablet to everyone, and that's coming as a shock.
So like I say, I mean, this is just one of the case studies that we picked up. So one, I said, this is one of the problems that they identified that they found it difficult to track. They were, I mean, if I can always share that report with you, which says that there were like several demand side, several supply side solved problems, and there were solutions that were identified. What here the idea of taking this as a case study is there is for this particular problem, what was done to identify a solution. Yeah.
So, sir, one thing I think data mining is also one of the tools where we can use to track, because this is a general perception, and like that 80 crore, near about 80 crore people are using the mobile in India right now.
Right.
But mobile company and any mass communication type of company have the data that which person going to end the program, end the plan, and who is going to take recharge or not. So they will call. So already there is a mechanism like deep data mining or AI we can use to detect that type of thing, which can, I think, better way, because you are also using interface, technological interface, which we shown previously slide.
Right.
So I think if you add that thing, and we have the accessibility from the telecommunication company, so you got the data and you add the one thing, you get the even track. What, even not only one parameter, many parameters. Yes, I am pretty much sure that the awareness in the what is called ASA level, Anganwadi is not up to mark. Even that worker also don't know what is the implication of IVA tablets and other tablets as well. So we have need to awareness and track. There is a mechanism we can use it.
So I'm aware that there are several initiatives that are taking place. Yeah. So yes, I'm aware that MIT is doing certain initiatives for AI for health. We've also been in conversation with them, and there's also the initiatives that have been taken by various other ministries to bring, digital technologies and AI to enable better decision making, better tracking, better health care access, and all. My own sense, it's still at a very early stage, nascent stage. Use of AI and machine learning and all, or even data mining requires a large amount of data to be mined and taken care of. So I believe those are stages where we will be crossing over a period of time. Okay.
Last hand.
Yeah.
30 seconds.
Yes.
Yeah, thank you.
On this.
My name is Shashank.
Yeah, Shashank.
People to People Foundation.
Okay.
The same things we are also facing in. We are actually doing one project with the ITC on West Bengal as well in Assam. So where we are strengthening the VHSNC's community. So there I will getting a very good results from VHSNC, and VHSNC also playing a good role to catch up such kinds of things, just like for nutrition
Right.
or for anemia, and many more indicators we are catching through the VHSNC. And the result, as we know, VHSNCs already exist in Indian context, as the status
Yeah.
but not in a proper functional way. So when we started to work on strengthening, reviving, and to just, as you said, you are just co-create with the people. So that is the right way, the same thing we did. And now we are getting a good result from that. So if we are strengthening the health structure as well, then we can also get a good result. And second, as the brother is saying about the technology, as we are the people who are working on the ground, we know what kinds of people we have and what kinds of people we are dealing. अब हम अच्छे से टेक्नोलॉजी समझते हैं, वो चीज़ों को नहीं समझते हैं. हमें उन्हें समझना और हमें समझना. Just like मैम ने उससे बात बोली कि गुरु जी का एक faith है. तो जब हम we create a faith on the community ना, then they are ready to accept our ideas and thoughts. तो फिर cooperation आता है, then हम कुछ कर पाते हैं. अच्छा.
I've got nothing to add to that. That's a great point made. Fantastic. Okay, I'll take you to Africa now. So this is something that happened in Africa, where we are finding that their health systems is finding it difficult to manage their medical equipment. When I say right from operations to maintenance to post maintenance rollout and all, so they were facing that problem. And I'm just going to open it for another 2 minutes. How do you think we, as using Living Lab, one would go into solutioning for this? Look at the 6 principles that we adopted, that characteristics of a living lab. User engagement, the user needs, all those elements that we did look at, and just any thought. Okay, let me just move it to the next. So basically what we did is we had, again, it's about engaging various stakeholders, some multi-stakeholder involvement. It was not just we went to the technicians, or we just went to the medical store owners or medical store managers. We looked at various cadres of people who are engaged with this entire device management system and tried to identify what are the problems. So we looked at these groups plus at the national level, and based on that we tried to identify what solutions can come in. Now these solutions were integrated into the government system, and they had set up they had a very rudimentary software system, but the software that got upgraded was done in consultation with people on ground who are handling these equipment, so that their specific needs are met, they are able to manage those software better, and then got integrated into the system. I'm just going into a very small capsular thing. It's not that it just happened over a period of few days and weeks. It was a very long process. Multiple steps were involved into it. Third is, this is another interesting case, COVID-19 period. I think Zambia was facing a lot of problem related to vaccine acceptance. We all are aware of vaccine hesitancy that happened. And we went about solutioning for that, again using the Living Labs approach. So there we worked with partners. And here when I mean partners, they were not just people on the community or the health workers, but also organizations which were involved at the front line of delivering healthcare services. So based on these consultations, we worked with them to create 5 personas. It was not what Path created. It was not what these partner organizations created. These 5 personas were created by people from the community, by the healthcare workers, to say, okay, these are the 5 different kinds of personas that people have, those who are hesitant to vaccine acceptation, those who are accepting vaccines, those would be the voice of science, those would be the voice of, let's say, the community. There were 5 different personas created. Based on that, health messages were created. What we did do is we evolved it over a period of time. So it was not that these 5 personas were set and that's it, and all health messaging happened on those 5 personas. But as, let's say, health vaccine acceptance improved or it changed, the personas also evolved. So this is something that we did in Zambia for almost 3 years to improve vaccine acceptance using the Living Labs approach. I'll quickly come to the lessons that we learned. I mean, over the 7 years, and as I said, we have done it over 72 projects. I just picked up small nuggets from 3 projects that we've done, one in Kenya, one in Zambia, and one in India. But overall, the lessons that we are able to draw from using the Living Labs approaches, it prioritizes co-creation. It simply cannot work if there's no co-creation. What we have seen it brings in experience, and I think I'm going to look at that screen as well. Okay, so it brings in influences from the community. It brings in skills, knowledge, and all from the community. Local knowledge is extremely important when we look at Living Labs. and it ensures that the solutions that are created are relevant to the end users, to the end beneficiaries, and it is very specific to the local context. So that's what Living Lab does. It focuses on frugal innovation because, I mean, it builds on open source information. It builds on something that can be flexibly, adaptably used, and it builds on a lot of what is available in LMICs, in our public health systems. It doesn't draw anything from global north. It doesn't draw anything from the G7. Solutions are driven from what's there on the ground. So that makes it very frugal. It allows a lot of cost effectiveness happening in terms of solutioning. As I said, it really enables iterative learning, feedback, and development. I won't get into the details of this. It builds sustainable partnerships. And when we say sustainable partnership, it's not just we are engaging with one set of stakeholders. It ensures that we engage with multiple stakeholders, with the health facilities, with the health staff working there, ensure that the solutions that are developed, it is developed mutually. It is a mutual learning process. They learn, we adapt, they adapt, and so it's all a common movement towards a solution, and it builds long-term sustainable partnerships. One of the biggest things is how to take it to scale. And because your solutions are frugal, because the solutions are being set up in a low resource setting, and it is set up with minimal externalities, it ensures that the solutions are scalable. Not just scalable within one system, they are also adaptable and scalable into other systems as well. We've seen some of the things that we have done with Living Labs in one country in Africa get scaled up to other countries. Adapted, I won't say it got scaled up as it is. Nothing gets scaled up as is except technology. But adapting and scaling is fairly easy when you use Living Labs as a model or as an approach to co-design solutions. That's it from my end. Thank you, guys. Thank you for your attention.